I'm going to go over the Aerogen Ultra adapter here for you guys. You guys are doing a trial in the emergency department. My understanding is 20 patients. And so first, before I kind of get into what's new and what you'll be using in the ED, I'll go over the core of the whole technology, which is the Solo here. Now, you guys have been using the ICU for a while, so it's probably a little bit of a rehash here. But basically, how this technology works is this is what we refer to as the Solo. Each one of these Solos, there's a little plate inside. That plate's made out of palladium, and there's roughly 1,000 4-micron size holes in each one of those plates. When you turn it on and that plate gets charged, it vibrates at 128,000 times per second and essentially pumps the drug through the plate. Now what you end up with is a particle size coming out of here, on average 3.2 microns. Or in other terms, 80% of the particles coming out of here are in that 1 to 5 micron range. That's really the sweet spot for lung deposition. Anything too much bigger than that, you're going to end up with it getting lost in the upper airway, and a lot of that drug's just going to end up in your stomach. Now, a nice image of that is here. Scintigraphy. You can see here on the right, this is what a jet nab is putting out. So most of the drug ends up in the patient's stomach. That's because the particle size is quite a bit larger, and a lot of the drug is left into the cup. Up to half the drug that you're prescribed or the physician's prescribing never even gets out of the device. This is going to nebulize 99.9% of whatever you get. Because of that smaller particle size, 9 times as much drug is reaching the patient's lungs. That's why it's become standard of care in hospitals across the country in the ICU. Specifically here in the Northwest, there's only a handful of hospitals not using us in the ICU. Now, what you guys are trialing is what we refer to as the Ultra adapter. What it is just a simple handheld piece with a mouthpiece. So your patients in respiratory distress in the emergency department can get that great lung deposition, and you can hit them hard and early before they get admitted into the hospital. So again, put your drug in here. It'll hold 6 mLs in here. Close it up, one button, turn it on, it's on. Now, it's not making any noise, it's not producing any flow, and so sometimes patients might say, hey, it's not on. Well, it's on. So in those instances, I like to pull it back a little bit. You can see the Venturi effect. The patient can see there's a nice plume of drug coming out of there. There's also a port at the bottom here, and this is the packaging you see. So it'll come with an O2 line. If you're using a mask, and any generic mask will fit on here, you can add a little bit of flow. For peds patients, 1 to 2 liters of flow is sufficient. For adults, up to 6 liters. You don't want to put too much flow in here, just enough to drive that drug through here, because remember, it's on. The drug is filling up that chamber. You just want a little bit to drive that through there and flush out some of that CO2. This is a valve mask. If you want, you can use an open aerosol mask, although the deposition is going to be better with these valve masks. And if you can get away with it, the mouthpiece is going to give you the best lung deposition for your patients. Now, in terms of outcomes, you guys wouldn't be looking at this if there wasn't strong data supporting outcomes, improvement in patient care. You can see the study there, 1,600 patient study done at St. John's Hospital in Detroit. They were able to show, using this product, a 32% reduction in admissions compared to the jet neb, as well as a 37-minute reduction in length of stay in the ED. And so that's a lot of patients who didn't have to get admitted, get put on a vent, spend a night in the hospital. They were basically hit hard early with a superior product, and it opened them up and allowed them to get sent home.